Chairperson, ladies and gentlemen, thank you for your invitation and for giving the industry the opportunity to give you a quick update on our pipeline and our innovations. What is quite important, just to, as a start, just to remember you that 2 days ago, we celebrate the 10th anniversary of the first implant of the first patients receive a Cribier Edwards valve at that time. So a lot of progress, and I think these days show the interest and also all the learnings that we get from those 10 years. What has driven heart valve innovation at Edwards Life Sciences? Not to come with new product, but also to come with new solutions to help you to avoid lifelong anticoagulations, to improve long-term hemodynamic performance, and also to reduce procedure invasiveness. And this is where we look at today. There was the previous talk from Mr. Young was showing the importance of hybrid surgical procedures, more complex patient, and this is also why we continue to really improve our devices in terms of rapid deployment platform. You see, we did a study recently with our new Edwards Intuiti devices that shows that for isolated AVR and also AVR and KBH, we have been able to reduce, cross-clamping time. So that helps you potentially to perform, more complex procedures in a less timely manner. As we said, in 10 years, we have built evidence, and those evidence came from more than 8,000 patients that have been followed in Edwards studies. Here are the latest publications, so from real world and with the source registry, which is the largest one, but also, with, as been described already today, with the partner trial, which is the first randomized prospective study on TAVI. And what we have learned, not only from today, but I think it was well said today, is we have been able to demonstrate, that AV block on our side has been really not been an issue, which is reported at 5 to 6%. Overall, as we can see, with 15 published studies with 1,700 patients. The valve circularity with the device has been also shown with 86% eccentricity index below 0.1. Accurate positioning and precise valve deployment, and larger anatomies with the addition of the Edwards SAPIEN XT29. What is missing and what remained a challenge, and I think it has been well described, and this is something that we would like to address for the future, is residual PV leaks with new valve design, embolic events as described before with Umbrella, but also, a study which is called TAVI. Aortic insufficiency, again with new valve design, and patient access, which will be addressed by new valve design with low-profile delivery system, but also availability of routes, as has been described today, such as the transaortic one. In 2012, so this year, I would say very soon, the SAPIEN XT29 will be also available via the transfemoral route. And you can see here from the PREVAIL TS study, the excellent result on the top line of the 29 cohort patients that was done with no coronary obstruction for this one, which shows that that was not an issue to have a slightly bigger size valve. What does this give it to you is to expand your treatment options, moving from 18 to 27 and up to 28 millimeter annulus size valve with those 3 valves. It was also described this morning the adjunction of a new route, which is for us the transaortic route, but also where we wanted to come is a new standard for the transapical and the transaortic routes. The transfemoral and transapical routes were the most studied across the different studies that we've seen, but also what we want to do here is to have this approach for patients that are not suitable for transfemoral or transapical, to have a versatile product which will be shorter and low profile, continue to deliver accurate and predictable placement, but also to be used with all size of SAPIEN XT valve with one devices. I will not give you too much details for time purposes on the embolic protection device that we are working on, But it's quite important to tell you that we are working also on a randomized prospective study, which is called TAVI. We'll try to better understand, the peri-procedure issues, but also the late embolic event. So looking at anticoagulation protocol. In this year, we'll be starting to do 2 new valve platforms. Expect to start CE mark trial in 2012. The new SAPIEN valve generation, which is almost what we can say is SAPIEN 3. It's an ultra-low profile balloon expandable valve platform. The goal is to find a way to reduce a third PV leak with this new design, to lower profile, to deliver this valve through 14 French issues, but also to reduce the profile on the transapical approach for 18 French. We also would like to continue to use the treated bovine pericardial tissue leaflets, as we believe, for durability. This valve will continue to have a discrete length to anchor into the annulus. The second valve is the Edwards Santera. The first in man has been done recently. And this valve is already a project that was in development for 10 years in Edwards. What we would like to come with a motorized delivery system for stable deployment and single operator use. It will be a repositionable device. Will be delivered through a 14 French issues. Will be, again, discrete and much more size than what is on the market today. And would like to continue to have this treated as well with bovine pericardial tissue leaflets. This kind of new design will help us maybe to address also aortic insufficiency, which will be suitable for larger annuli. Will not be depending on calcification for anchoring, hoping also not to exert dilatation force on the annulus or aorta, and of course mitigates the ongoing root dilatation for this kind of procedures. I think I'm just on time, so I would like to thank you for your attention and the privilege of the floor.
Any burning questions? Quick point, you have a self-expanding valve on its way. Is that specifically, do you think, apart from the AR, to address the valve-in-valve population?
Yeah, there's a few things that you will see for bicuspid valve also for younger patients. So we believe that there will be some patients profile that could benefit from this specific design, and not necessarily only valve-in-valve, but other type of patient profile.
Can I ask you to just elaborate on the repositioning valve? How does that technique work? How can you reposition?
For some reason I cannot tell you too much and disclose too much on this one today, but this is the aim, is to find a way to reposition that valve. The balloon expandable is very easy and accurate to position, with now the slow inflation. What we want is to make this motorized system very useful for one single operator for the self-expandable technology. You will hear more in the coming weeks and months.
Well, thank you very much, Jean-Paul.
Thank you.
Going on the list, we have Xavier, who's going to speak on behalf of Medtronic. Thank you.
Good afternoon. Okay. First of all, thank you so much for the invitation. I'm Xavier Bertrand, in charge of the structural heart for Europe and Canada for Medtronic. As you could hear, to speak about the pipeline in TAVI, you have to have a French accent, so that's the second one in a row. I'm going to open this here. So we are very excited about our pipeline, and in 5 minutes I have to say that it's going to be a challenge, but we are going to do it. You know the core valve design. Actually, even before I go there, the one strategic intent we have when we develop our pipeline in TAVI, but also in our surgical valve business, is really about simplicity, providing you with simplicity and also providing you with as many treatment options as possible. So when you look at our valve portfolio from mechanical, stentless, sutureless, and also TAVI, And then within TAVI, we're trying to develop as many sizes possibilities as possible and as many access route as possible as well. And that's really what is driving the development of our pipeline at Medtronic. If I look back very quickly at the last 18 months, we've launched, as you know, we've expanded the sizes with the 31 millimeter. We have also been granted with approval for the direct aortic and subclavian access. I mean, CoreValve is the only valve approved for those two indications so far. And we've also launched the AccuTrack stability system, delivery system that has proven to reduce one of the issues we had, which is higher pacemaker rates. And we've seen since the launch of this product that those centers that have adopted this technology have seen their pacemaker rates reducing. And you will see data actually in the coming, before the end of the year on that, and actually here in the UK especially. We've also invested a lot in clinical, because as long as a product, until a product is not proven clinically, it's just a concept. So we will see many concepts in the presentation, but we have to prove them clinically, and that's where we are investing in. When you think about it, within the next year or so, we will have around 10,000 patients in clinical trial. Now, what are we going to do over the next 18 months? So we are going to improve the delivery system, the valve design, and also the procedure itself. So if I start with the delivery system, by the end of the year, actually most probably during this summer, so it's hot as the press, we are going to launch a new delivery system with many new improvements, but I think the most important one perhaps are a better ease of use with a hydrophilic coating for the deliverability of the system, and more importantly, one-on-one translation from the handle to the valve, which will even further improve the accuracy and control of the deployment, which we heard this morning is one also important element. And also this delivery system will come in a shorter version, so in a long and short length, and the short length will be obviously more suitable to subclavian, but also direct aortic. I heard carotid this morning, even though it's still off-label cases. So there as well, we are trying not only to have different valve design per indication or per anatomy, but also more and more you will see delivery system that will be specifically designed per access route. We are working on the next generation CoreValve, which is basically building on the strength of CoreValve. A lot of companies now are focusing on a self-expanding valve. We are very happy with self-expanding design, so we're keeping it. And we are just trying to even further improve it. And what we are doing there is reducing the frame height, coming back to the pacemaker rates that we heard about earlier today. And also this new design will enable recapturability of the valve. Obviously the design goals that we have is lower PVL, more accurate positioning and pacemaker rates, because we have to recognize that we have still room to improve on those three items. The good news is that we are going to launch this second generation, or fourth generation I should say, this year, in this calendar year, with a smaller size valve, with a 23 millimeter valve, and this will be launched in this calendar year, most probably right after the summer. But again, for us, the idea, sorry, I come back here. The idea for us is really to provide you with as many options as possible, and sizes options are extremely important so that we adapt to the device to the patient and not the patient to the device. We are also going to launch in the next 18 months another valve platform, so two valve platforms, which is the Engager valve. Some of you may have heard about it already. This results from the acquisition we did of the Ventor company, an Israeli-based company, about at the same time of CoreValve 3-4 years ago. We have changed the initial design of the valve, and with the help of investigators, we've modified that. And we are now very happy with the design that we currently have, and we are enrolling pretty fast in our CE-mark trial. It's going very well, and this valve should most probably be approved within the next, let's say, 12 to 14 months in Europe. It is the first generation of this valve would be a transapical route, which is, again, one of the access that we are missing. I heard the debate this morning and early this afternoon. I think it's critical that we can offer you all access route possible. The more the TAVI therapy will develop, the more we will see that patients are different, indications are different. We spoke about valve in valve. There are specific patient population and anatomies that have to be taken into account. So there is probably room for every single access route, and that's why we are trying to develop all of them. The engager will be a transapical valve and will also come as a direct aortic valve with a specific delivery system as well for the direct aortic delivery. So with that, we will have more access options. Transfemoral, subclavian, direct aortic, and transapical as soon as we get the engager valve approved. For the sake of time, I did not want to spend too much time on what is beyond 18 months, but we just in a nutshell, we are also working on a mitral replacement program. We think that transcatheter mitral repairs is kind of a challenge based on the previous presentation we saw. So we rather focus on replacing the valve on a transcatheter basis. And that's also one of the reasons why we also continue the investment on the Venture project and transapical access. I completely agree with what was said earlier today. It is critical, especially for cardiac surgeons, to keep that access, because for mitral it's going to be critical. So the Venture program will translate also into a mitral program, but that will take probably more like 3 to 5 years than 18 months. And we're also working on a sutureless program on the surgical side. So to summarize, we are working on 3 areas. The valve design. By the end of this calendar year, we will launch 2 new valves. The next generation core valve 23 mm and the engager valve in the next, let's say, 14 months. We will launch a new delivery system with a specific size for direct aortic delivery. And I don't have time to speak about procedural solution, but it is, I think the TAVI procedure deserves to be treated as a procedure. It's not only the valve, it's what is around the valve. And we are heavily also looking into that, either in internal developments, as we have many other businesses at Medtronic where we can transfer technology from in endovascular treatment. And we are also looking at a few external possibilities. Thank you very much for your attention.
Any questions?
It's just a quick question, really. The engager is bovine pericardium, it's said.
Yeah.
But isn't the core valve porcine?
Yeah.
And what's the difference? Why are you changing from one to another?
We're not changing from one to the other. When we bought both companies, like, again, within a few months time frame, when we bought core valve and then Venture a few months later, this is the technology they had, so we just inherited those 2 technologies.
Can I just ask one question that Anita asked earlier? Are you able to discuss with us how you're going to recapture and reposition your valve?
I'm afraid I will have the same limitations. I can just tell you that it's a matter of the valve design. It's also a matter of the delivery system. So for us, it will be a combination of those two elements. So the 23 mm next generation will be first launched, and then will be recapturable once we launch the new delivery system. That's all I can tell you about it.
The 23 mm, is that going to be delivered with a smaller delivery catheter?
Yeah, that catheter will be, you mean in terms of profile or length?
Well, no, the profile.
No, the profile would be the same profile.
Yeah.
We really had to prioritize, and we thought that recapturability would be the first priority for us. It will come in a smaller profile later on. It's part of the project, but it will take more time.
Do you have any, you mentioned in your talk that you would also address parvalvular leakage. Do you have any innovation for that? Because, I mean, clearly it comes out now with the 2-year results from Partner that parvalvular leakage is a bigger problem than we hoped in the past, or let's say at least cardiologists, surgeons were less convinced about that. And for example, from the UK registry data, we know that regurgitation plays a significant role and may play a bigger role with the core. I don't know, but do you have something for that problem in mind?
Yeah. I just can't share with you here today too much detail, but specifically the skirt of that valve will address that issue. And I would say it will probably never address it fully. And you know, I heard the discussion today, and I think all of you here in the room of the surgeons that are implanting those products are also innovators in the way you handle the product, in the way you optimize what we give you. And I think the health team itself, and the way you select the patient, and the way the imaging is being used, will in a way also improve concomitantly to that PVL. Yeah.
You haven't had too much of surgical input in the beginning of CoreValve, right?
Say that again?
You haven't had enough surgical input in the beginning of CoreValve, which
Yeah.
is not your responsibility, but maybe that was a mistake.
No, let me address that. I mean, when we bought CoreValve, it was sorry to take a bit more time, but it was a startup that obviously was, you know, focusing on the cardiologist. I think it's fair to say that. I would just tell you two things. We bought Ventor the same week, almost, which was a transapical approach. I'm in charge of cardiac surgery as well as CoreValve, and our global lead is a cardiac surgeon, John Liddy. So that's all I have to say about that. We really do support the health team, believe me. I will not be here otherwise today.
Okay, thank you very much. There's two more to go, so if I can invite St Jude and it's Urban.
Trying to close it.
Thanks so much for inviting me. I want to talk about our Transapical program. There are three words that has been built into this program. It's a program that has been designed and made from in-house, and what has been going into it is what we call resheet, reposition, and retrieve. And just to give you an example of this is a patient that had a Portico device implanted by a person that was used to implant CoreValve. So they they start to implant the device a little bit lower in the ventricle, and then wanted to push it up a little bit to get the perfect position for a CoreValve. And the interesting thing is here, what happened there. I don't know if you really saw that, but it pops out above the annulus. And if you sit in this situation, of course, you have a big problem. But with this device, you just need in situ to back the valve back into the catheter and just restart your procedure again. The interesting thing is with the valve also that the valve itself sits extremely low into the stent frame, and it's a self-expanding 19-0. And this was the result from this patient. Good position, about 4 millimeters annulus protrusion. And this is what is intended with this valve. Looking at the valve, you think that, oh, this is just another CoreValve, but there's a lot of difference between this valve and the CoreValve. And I think that the new Medtronic valve, or Edwards valve, would most likely look a little bit the same. The valve is sitting very low. It's a bovine pericardium valve. On the outside, there is a skirt, a porcine pericardial skirt. And there is a theory behind that, because the big cell structure in that area where you're going to position the valve in the annulus, there is a possibility for at least smaller nodules of calcium to sink in a little bit towards the skirt. The skirt will still be protecting the bovine pericardium, and it will hopefully help out to reduce the amount of paravalvular leak. The intention of the device is to be placed about 4 millimeters subannular position like this, and hopefully that will reduce the amount of pacemaker needs. There will be two systems, one transapical, which will be a sheetless system. It will have an integrated sheet, 24 French outer diameter, and it's going to be annulus deployment first. And then the transfemoral system that we have now ongoing in CE-mark trials, 18 French true outer diameter and 12 French shaft. Of course, we know that there is no annulus that is completely round, and you will see many different configurations of annulus. So the whole system is, of course, also tested to have full coaptation, even if configuration of the annulus will be skewed or non-circular or whatever kind of configuration you have. The first-in-man series was done. We did 20 patients first-in-man with our transfemoral system, and 10 was done in Belfast with Ganesh Manoharan, and 10 was done with John Webb and Rodet up in Canada. Manoharan, he presented the first 10 cases at TCT last year, and it was just a 30-day follow-up for the first 10 patients, and we were very encouraged when we saw that. We had no death, we had no strokes, we had no new pacemaker insertions. We had 3 left bundle branch block, which 2 of them were present or came already before the valve system was introduced into the patient. Aortic regurgitation over mild was 0, and vascular complications 0, myocardial infarction 0, and length of stay was about 5.2 days. So we were encouraged by that, so we started our CE Mark trial, which is now ongoing in 3 UK centres. It's Belfast, it's St Thomas in London, and it's Leicester with Dr. Novak. And there will be 2 German centres just initiated for this. The timeline is also that the Transapical system will come just within a 3-4 month period now, and then the different valve sizes will be added up to that. Echo data, mean gradient, of course, it looks good, and also the aortic valve area looked good in this series. Now I kept it very short.
Thank you for that, because we are running over time. Any burning questions?
Can I just ask one point? That you showed your valve being retrieved back, Urban.
Yeah.
How far can you actually push it out before you can no longer pull it back in?
I think that this is one of the biggest advantages with the system. When you deploy the valve, you can deploy it up to 90%. You can deploy it and set it in the annulus where you want it, as long as you don't release the retention tab, that is the system that pulls the valve back into the system. You can stand there and look at the whole thing. You can ask your imaging technologies to come in and take whatever sort of images they want. You can give some root shots of contrast dye to see if you have problems with paravalvular leak. So it takes totally the sort of anxiety of having any problem with doing this very fast. I mean, you can go eat a lunch while having this device sitting there before you decide to release it.
Thank you. On that note, we'll move on to our last presenter, Katrina from JenaValve. Thank you very much.
So good afternoon, and thank you very much for the invitation to speak today. So I will talk about the JenaValve technology. So the JenaValve is a transapical TAVI system. It's a self-expanding nitinol stent with flexible stent posts. It's a porcine aortic root valve and has a unique clipping mechanism, which I will show later. And another special feature is anatomical feeler-guided positioning. And also you don't need a rapid pacing during implantation. It comes in 3 sizes, 23, 25, 27, and covers 21 to 27 millimeter annulus. And it's a sheath-left 32 French delivery system, which is comparable to a 28 French system. So it is commercialized actually since October 2011, so we got CE mark. And we will do the first UK implantation actually next week at King's College. Professor Wendler will do that. So here you can see the technology. So it's a catheter, is highly visible, and you can see it's a flexible catheter shaft. You will proceed to a little bit above the aortic annulus. Then when you are there, you unsheath the feelers, and we have these 3 feelers which have markers at the end, so you can very well see where you are. And the idea is that you put the feelers into the aortic cusps. And this step now is fully retrievable. So if you are not happy with your position, you can retrieve it, you can put the feelers back in, and you can actually remove the system. So here, so you can see you put down the feelers into the aortic cusp. You check on the floor if you're in the correct position, and you can see it, and as well you have a tactile feedback. So you feel it on the catheter when you're in the cusp at down at the right position. Then you clip the feelers. You clip between the native aortic valve and if you release, it's almost like a paper clip. You have the native valve in between the feelers and the stent, and then you can appreciate here it is released from the catheter. Afterwards we're checking, and you see there's no leakage. Also the osteas is free, the coronary osteas are free, and I want to say with this design, the coronary ostia will always be free, because they will never stand, because it's anatomically aligned, and there will never stand material be across the ostium. So if you look at the system, it's the key characteristics of the second generation device. It's a low-profile design. It has this unique JenaClip anchoring mechanism, and so that is active fixation and gives resistance to migration. And also, what one advantage is, you don't need any calcium for this, and actually we have treated aortic insufficiency cases with this too so far with this device, very successful. And it is fully retrievable and repositioning in the step 1 and 2. And you don't need any rapid pacing during the prosthesis release, so you have really time. And also that you don't see any pressure loss, and it maintains hemodynamic flow. So if you look at the clinical research program, we had a first in man which proved our concept. We have a CE mark currently in 6 months follow-up, which will be shown the result at PCR, and we will start a post-market study very soon. So just quickly, the data from the CE mark trial, we had up to 70 patients, the typical population with severe aortic valve stenosis. Typical inclusion criteria, Professor Moore from Leipzig was a principal investigator, and like I said, the patients are in 6 months follow-up. We had enrolled at 7 sites, 76 patients. Baseline characteristics, due to time I don't want to go through all of them, just I want to point out, we had a logistic Euroscore from 28.4. And if we look at the major complication at 30 days, we had an encouraging death rate of 7.6, cardiac deaths 3%, we had 2 strokes, we had no myocardial infarction, we had 4 conversions to open heart surgery, renal failure 3, endocarditis 1, and pacemaker implantation 6, and 2 of them actually were due to balloon valvoplasty, so before even our device was inserted. At 3 months, we have a death rate of 19.4, cardiac death 9%, and we added 1 more stroke, and that no more other events. If you look at the echographic outcomes, peak gradient was 67 down to 20 at post-procedure, and durable results to 3 months. And the mean gradient was 40.6 baseline, and then 10 and 10 at post-procedure in 3 months. Paravalvular leak, we had almost 50% had none, 39% had grade 1, and grade 2, 13.6%, and we had no greater than grade 2, At 3 months, we had a reduction in grade 2 to 8.1 and almost 50% grade 1 and 43.2 grade none. Effective office area has significantly improved, and from baseline 0.7 to 1.7 and 3 months 1.6, and as expected, left ventricular fraction did not significant change. So quickly, the post-market studies. This will be a study which starts this month. It will include 15 to 20 sites, Euro-BRICE, 150 to 180 patients. It's a real-world population. Primary endpoint will be 30-day mortality, and the principal investigators are Professor Wendler and Professor Doll. And we also, of course, have a transfemoral in development. I can't show too much right now, but so we're hoping that we starting our clinical trial in the middle of the year, and the first in-man trial, and so that will be in development and coming soon. So as a conclusion, the JenaValve device offers a new treatment option for transapical TAVI for patients with severe aortic stenosis and high surgical risk. And thank you for your attention.
Thank you, Katrina. Any questions? I just want one point clarifying. Did you say that you don't cope very well with calcium?
No, we do.
Calcium.
No, we do. We do calcium as well, of course. Okay. Most aortic stenosis are calcified. But we also, because of the unique clipping mechanism, we can actually also treat, or we don't need calcium for anchoring. So we can also treat, which we did already, aortic insufficiency, actually, where sometimes there's no calcium at all.
Can I just ask then, how would this valve perform in a true bicuspid aortic stenosis?
It's off-label, so probably not. Actually, we had one in a clinical trial, and that didn't work so well. So no, it's really off-label. I mean, it's contraindication, bicuspid.
Anyway. Well, in that case, we'll end it there. I'd like to thank everybody who's spoken all through the day and all the